welcome everyone. I'm Adrienne Lindsay. I'm the director for the Center for Substance Use Training and Telementoring at Be Well, Texas, which is housed at UT Health San Antonio. So welcome to our Texas sessions. If you're familiar with our Texas Substance Use Symposium, the sessions are really webinars that we offer between the symposia to continue the conversation around important policy matters, emerging topics, implementation strategies, and the like, so that we continue to converse throughout the year. So I'm excited about our panel today. It's a DIY approach to crafting your hospital's blueprint for addiction care with our colleagues from the Shout Texas program, the Support Hospital Opioid Use Disorder Treatment Program. A couple quick housekeeping items, kind of your usual webinar things. We do have everyone's video and audio disabled. This just so we don't get some background noise or distractions during the panel. And we'd encourage you to use the chat box for your commentary, but note there is also a Q&A box specifically for questions, and we'll take those at the end. So if you navigate to the bottom of your screen, kind of hover around the bottom, you'll see Q&A, and you can plug in those questions as you go so you don't forget. All right, next slide. Just a couple quick attributions in our disclosures. We wanted to mention that funding for the Shout Texas program is supported by Texas Health and Human Services Commission through a SAMHSA grant, and that the views of our panelists today are their own and do not necessarily reflect the official views of the University of Texas system. And why some of you may be here, free CE, right? We always try to offer free continuing education credits. You can get 1 hour of CEU credits today. Just be sure that you complete that post-session survey. We will drop the link to the survey in the chat. We'll also send that around by email afterwards, but be sure to select on that survey that you'd like CE, and you'll get your certificate from us in a few weeks by email. Okay, so now is my opportunity to introduce my fabulous colleague, Alanna Boulton. Alanna is the Program Administrator for Addiction Care Ecosystems at Dell Medical School at the University of Texas at Austin in the Department of Internal Medicine. She's also the Director of Shout Texas. She holds dual master's degrees in health sciences and healthcare administration and is also a certified PMP. She presently serves on the Travis County Substance Use Planning Work Group and really has extensive experience in healthcare service delivery systems and coverage programs for underserved populations. That is the very, very short list of her expertise and all of her accomplishments, but in the spirit of time and giving a lot of time to our panelists today, I'm going to turn it over to Alanna to tell you a little bit more about the Shout Texas program and then introduce her colleagues. Turning it over to you, Alanna.
Okay. Thank you so much, Adrienne, and to the whole Be Well and CSTAT team for hosting me and my fabulous colleagues that I'm going to introduce here shortly, and giving us an opportunity to share our exciting work that is very dear to my heart at Shout Texas. Can we go to the next slide, please? Our learning objectives today are really just going to be providing an opportunity for 3 of my dearest colleagues to share their lessons learned and approaches to implementing hospital-based opioid use treatment programs in various hospitals across Texas, and then talk a little bit about the model that we used with which to do that. Next slide. And just for some very basic framing here for everybody, Shout Texas is, again, the Support Hospital Opioid Use Disorder Treatment in Texas program. And we are an education and dissemination program that aims to increase access to evidence-based treatment for opioid use disorder and other substance use disorders in acute care hospitals across Texas. We do this by partnering with these hospitals, helping them to identify and develop their clinical champions, identify and develop their project teams, and help them work through various barriers and limitations in their unique practice settings to turn on similar Shout Texas teams and help increase access to care for patients in their hospital settings. Next slide. This is a really kind of busy slide, and I apologize. But we used a validated implementation science approach to expand the Shout Texas model across Texas. I'm not going to bore everybody with going through all of these things, but Ninfa Cruz, one of my wonderful colleagues, has put in the chat a paper that we published last year or earlier this year that describes this much better. But we used the Replicating Effective Programs framework, or the REP framework, which essentially allows you to identify a program that is successful. So for us, that was our pilot program at our hospital at Del Seton Medical Center in Austin. Identify that program as successful, figure out what was successful and what needed to be tweaked about it, make those changes, and then scale that at large across the state. So again, the paper that's in the chat will explain how we did this in much more detail, but just wanted to let everyone know that we did use a validated approach to do this. So we have quite a few lessons learned about what worked and what didn't work, and ways to tweak this for each individual practice setting. And then I think next slide, and we will move on to introducing our panelists. And much like Adrian, I am going to try to minimize the amount of talking that I do, but I am thrilled to introduce you to some of my favorite people. We have Dr. Dustin DeMoss joining us from JPS, Dr. Zachary Freeland from Baylor University Medical Center, and Dr. Jan Ramesh from Del Seton Medical Center in Austin. I'm going to start with Dr. DeMoss. Dustin DeMoss completed his undergraduate medical education at the Texas College of Osteopathic Medicine in 2009. He then did a 5-year combined residency in internal medicine and psychiatry at Tulane in New Orleans. After serving as chief resident there for 4 years, he graduated from his residency program and came back to Texas, thank goodness, with his wife and his young children, and settled in Fort Worth. He joined the University of North Texas Health Science Center and John Peter Smith Hospital and began work on research, education, and quality patient care, and obtained medical certification along the way. Currently, Dr. DeMoss serves as the Psychiatry Residency Training Director and the Vice Chair of Education for the Department of Psychiatry and Behavioral Health. And Dr. DeMoss is passionate about treating those with substance use disorders and has helped spearhead JPS's effort to start a clinical service line dedicated to this cause. Dustin, thank you so much for being here today. Would you mind giving us a brief kind of overview of the hospital-based model that you implemented at JPS and how you kind of went about doing that?
Yeah, Alanna, thanks so much for having me, and thanks to all the Shout Be Well Texas folks for this effort and being just a huge support model for us and other hubs. So currently, our kind of addiction service line is really made up of a bunch of provider champions, physicians, nurse practitioners, PAs. A lot of us in multi, different areas got together and said, we don't have adequate services. Let's get together and do something about it. And so with the help of this grant, we also received another SAMHSA grant, just kind of, seed funding to help build what at the time we really wanted to emphasize, which was low barrier care. So we got a bridge clinic. And that was really just the nidus of proof that we needed to make the argument that this is important, it's sustainable, and it's scalable. And there's a ton of interest in the patients, really appreciate it. And so that's allowed us to go from a bridge clinic to an outpatient clinic to a consult service and a lot of other initiatives. And so that's kind of our current status right now, Alanna.
Perfect. Thanks so much, Dustin, and thanks again for joining us today.
Absolutely.
Our next panelist is Dr. Zachary Freeland. Zach earned his medical degree from UT Southwestern and then completed his residency in internal medicine at Baylor University in Dallas. He works as a hospitalist in downtown Baltimore during the height of the opioid epidemic. That sparked his interest in providing compassionate care for people with opioid use disorder. He then returned to BUMC in 2020, right during the COVID pandemic, and began working to implement best practices for OUD treatment at BUMC. In 2022, they partnered with us here at Shout Texas and formed their OUD consult team, which serves to evaluate patients with OUD, initiate medication-based treatment, and link patients to outpatient treatment. To date, the team has engaged over 500 patients. Zach also co-directs the addiction medicine elective for the residency program, and in his free time, he enjoys spending time with his wife and his cat, kayaking on White Rock Lake, and volunteering as a master naturalist. And I don't actually know what that means, so you might need to tell us, give us a little bit of detail on that, Zach, and then tell us a little bit about your program at BUMC. You're on mute.
Sorry. Thank you for the intro, Alanna. To answer your first question, a master naturalist is kind of an amateur ecologist who is dedicated to the education and conservation of our native ecosystems. But to answer the bigger question, Baylor is a large private, not-for-profit teaching hospital in Dallas, and we have actually one of the, if maybe even the largest single site hospitalist group in the country. We do not have anybody here who is boarded in addiction medicine or addiction psychiatry. Historically, our psychiatry consult service has been pretty lean and hasn't had the bandwidth to do much for patients with substance use disorders. And so there was this kind of void. And so what we did was we created a consult service out of our many hospitalists to fill that void. And so we function as a consult service. We're staffed 7 days a week, 365 days a year. We'll see patients hospital-wide with opioid use disorder, offer medication-based treatment, and help connect them to outpatient follow-up. And then we're also supported by a larger interdisciplinary work group with representatives and buy-in from case management, social work. We have members of our palliative care service lines, and then also very just excellent, gracious support from our hospitalist group's leadership.
Wonderful. Thank you so much, Zach. And then finally, our last panelist today is Dr. Ramesh, who's a close colleague of mine. Jan is an internal medicine assistant professor of internal medicine at Dell Medical School. And she also completed her medical degree and residency at UT Southwestern. So we've got two UT Southwestern folks on the call today. She then completed her hospitalist fellowship in patient safety and quality at Dell Med, then joined us as faculty in 2021. Jan's clinical and research interests are in addiction medicine and particularly in patients with alcohol use disorder. She's interested in exploring new ways to deliver evidence-based treatment to those patients and in reducing the stigma of addiction across the board. She's a member of our hospital's B team, which is kind of the original team that sparked all of this work, or the buprenorphine team, which is a consultation team that provides patients with opioid use disorder access to treatment. And she's also a hub member of BeWell's TXRX Echo series, which just happened yesterday. Thank you so much for joining us, Jan. Do you want to give us a brief overview of your program at Dell Seton?
Yeah, thanks so much, Alanna. So I kind of joined Dell Med in 2020, and the B team had started a little bit before me with my lovely former colleagues, Rich Botner and Nick Christian. The B team sort of grew out of a need for reducing readmissions, really. They noticed that a lot of patients who were being readmitted to the hospital carried a diagnosis of opioid use disorder, and nothing was really being done for them at that time. And so Rich Botner did some research on buprenorphine and found that it was the new evidence-based standard of care treatment for patients that saved lives, and put together almost like a grassroots consult team, which is called the B team. And this included not just hospitalists, but pharmacists, nurses, case managers, to all come together and show the rest of the people in the hospital that it was really easy to prescribe buprenorphine with an X waiver at that time when it was still required, and then kind of connect patients to outpatient care. So it started out as a hospitalist-led consult team with a lot of multidisciplinary support. and still sort of functions in that way, although we are trying to move on from a traditional consult service and instead empower hospitalists to just start buprenorphine and connect patients to outpatient care themselves without necessarily having to consult another physician to do it for them. Because like Dr. Freeland mentioned, our addiction consult service is quite lean. We do have one addiction boarded psychiatrist, but they don't necessarily have the bandwidth to see all the substance use patients. So we do try to empower our hospitalists to kind of do it ourselves. And we still do have great case management and social work support for these patients.
Thanks so much, Jan. And thanks to all of our panelists for joining us today. We're going to jump in now to the panel discussion. Before we do that, just a reminder to our attendees, we have a handful of prepped questions that we're going to start with, but we do have dedicated time in about 20 minutes to do audience questions. So if you have questions that come up during any part of the discussion that you're about to hear or that are related to any other topics in the realm of opioid use or substance use treatment in hospitals, please feel free to enter those into the Q&A box. So there's two boxes at the bottom of your screen. One's a chat, one's a Q&A. Feel free to use the chat as a chat feature, but if you have questions that you would like the panelists to review and answer, make sure those go in the Q&A box because that's where we will be looking for them. And then we will have time later for additional questions as well. So I'm going to just jump right in. I'm going to start with you, Zach. Would you mind giving us a little bit of framing for the rest of the discussion regarding why this is important to think about now? Why is it important for hospitals specifically to take a more active role in creating their own plans or strategies or blueprints for addiction care, whether that's opioids or otherwise?
Yeah, so addiction care, I think in general, and especially with regard to the opioid epidemic, it's one of those fields where, to kind of echo what Jan was saying, the the number of patients who need care just grossly outstrips the capacity of people who do this full time, people who are boarded in those fields. And so we really need to build, to expand this skill set to more of our workforce. And I think, the people on the front lines, internal medicine, family medicine, psychiatry, physicians, and advanced practice providers are very well situated to own this problem. And I think it's very, well within our skill set to own this. And so and I think the need is probably greater than ever. And I think it's important that we have different hospitals and different systems approach this in different ways, because every hospital, every system is different in terms of the resources available and the needs. For example, as I was saying, we have a very large, robust hospitalist group that we could draw from, and we don't have other service lines like psychiatry nearly as much. I think kind of practice setting also makes a big difference. Whether you work for a, for example, if you work for a private for-profit group, you're going to at a more traditional academic center, and you're salaried. So, sorry, we okay?
I think so. Yeah, we had maybe a little blip in your audio, but I think we're back caught up now.
Okay. Sorry about that. I was going to say, to contrast that, if you're at a more traditional academic center, you may not have to make quite, and your paid salary. You may not have to make as much of a business case, but might be competing with other, research interests, quality improvement interests. So I think it just has to be kind of customized to what's going on at your shop.
Thanks, Zach. I appreciate that. Dustin or Jan, anything to add to that, or any other framing you'd like us all to consider as we walk through the rest of these questions today?
The only thing I would add to that is just because your question is, why is this important? I would look to what the community needs. And definitely in Fort Worth and Zach, I know in Dallas for sure, in Austin, most urban areas, the community, I mean, let's face it, even in rural areas, a lot of the community needs substance use treatment of any kind. And the way to go about that is identifying what those community needs are, and specifically the what are called the community health needs assessments that a lot of organizations do within a particular county or community. And they're published, widely available. So I think that's very useful when you're leveraging the why and why now specifically, at your specific institution.
Wonderful. Very well put. Dr. Ramesh, I saw you come off mute. You have something to add?
Yeah, I just wanted to add the importance of this work is, I mean, it's always been important, but really important now because I think this patient population that we serve has been largely neglected, stigmatized against, and turned away in some cases for when they seek care, and has led to a lot of distrust in the medical system. And if you don't reach out to them now and offer help, that mistrust will only grow. And with these populations of patients who are already kind of isolated in many ways and socioeconomically and disadvantaged, I think it's really, really important to find ways to reach them before it's too late.
Very well put. Thank you. I wondered, Dr. Ramesh, if you would mind expanding on that. How do you go about managing sort of that mind shift change or culture change that promotes the idea that treating opioid use disorder or any substance use disorder or treating these patients is something that should be just standard of care and is something that is within most clinicians' capabilities to do, as opposed to something that is complicated and needs to be handled by a specialist or something that is somebody else's job to do?
Yeah. So I think in the early days of the B team, what was really helpful in spreading this model of care was the fact that it was a very multidisciplinary team. They had pharmacists on board, nurses on board to kind of identify opportunities where clinicians could come in and start to think about a patient's substance use disorder. So if, a nurse reaches out to you saying like, hey, I think this patient might be in withdrawal, this patient might have a substance use disorder, or if a pharmacist reaches out to you saying like, hey, I think this patient might benefit from naloxone, I think it kind of puts you in the mindset that, addiction is something that can be seen and managed by everyone in some way, shape, or form. And it doesn't necessarily require specialized services. And then the other thing is this group of patients is very sick. We've all seen them over and over again. They get readmitted at really high rates. They come in with infections. And if they're not getting what they need at the hospital, they can be really challenging to treat, and they can be very challenging to engage in care. And so anything that makes that relationship better with that patient, I think people will be very quick to see. And I know in the early days of the B team, they would have like these very challenging patients who'd come in, be in extreme pain, extreme withdrawal. Nobody would know what to do. And when buprenorphine became a thing and became started on some of these patients, they became totally different people. And they were so grateful, lovely to take care of, got so much better. And that was very apparent to everyone on the care team, including nurses, physicians, pharmacists. And so those stories spread pretty quickly. And the positivity of the treatment that we can offer them becomes very clear to everyone involved in the institution and community.
Thanks, Jen. That's really meaningful and really, really deep. Dustin, I saw you nodding along while Dr. Ramesh was responding to that, and I would be curious what your feedback or response to that question is. Your hospital facility has involved probably the biggest number of units or services in this work. So I'm curious how you sort of tailored that messaging across multiple service lines, or other tips or tricks or learnings that you took from that process.
Yeah, so before I dive into that, I wanted to just add on like how do you change culture? And obviously, I think we've all heard the trope that culture eats strategy for lunch, right? But I find that the accumulation of minute changes over time is what makes the biggest effect. And so if it's, one meeting with one group, another meeting later on with another group, over time, year, 2 years, you're going to see some dividends from that investment. And so more so to your question, Alanna, we identified, so we started off with the stakeholders, who are seeing these patients. Obviously, it's the ER, it's the hospitalists, it's plenty of outpatient folks, although they may not recognize it, it's there, and our OB service. And so these patients are coming in from everywhere. And depending on the group that we're talking to, we tailor the message to the audience like you would any normal talk. So in that instance, if we're talking to a group of residents or fellows, then we do it from an educational lens. Like these are things that you can do. If we're talking to a group of nurses, we would tailor the message. Hey, if you really want to provide the best care for these folks, here's something that you're going to be seeing coming down. And then to a lot of folks who work in, the ER or OB triage or high pressure places where you're going to hear a lot of stigmatizing language. We often frame the message around let's get a win-win. Let's address some of your burnout and your frustration with seeing some of the same folks over and over for the same things, and let's do what's actually better for the patient by getting them on either medication or getting them to a bridge clinic or somewhere else where we can do more wraparound services. And so we've had good success with tailoring the message to the audience, showing them how easy it is to do the right thing. One of my colleagues, Dr. Detienne, I don't know if he's on, but one of the things that he loves to say is people want to do the right thing, so let's make it easy for them to do the right thing. And so when you make it easy for people to do the right thing, it usually gets done. So anyways, that's the pieces that I would add to Jan's comments.
I love that. Let's make it easy for people to do the right thing. I'm going to write that one down and make sure that's on a post-it note that I can see. I love that.
Indeed.
Dr. Freeland, anything that you would like to add? Your hospital facility is probably the largest. And I think the way that your model has been implemented, you've managed to recruit probably the largest number of non-specialty trained hospitalists who are willing to jump into this work. So how did you manage that recruitment, or how did you do that culture change or kind of convince folks to buy into this messaging and this idea?
Yeah. I think we've been blessed with people who just really have a passion for this. They recognize the need. They recognize, like Jan was saying, the stigma that these patients have been a victim to. One tool that I've found successful in kind of promoting culture change is just sharing success stories. And so sometimes when I'm reviewing cases at the end of the month, I won't lie, we have a lot of the patients who, we do the right thing when they're in the hospital, but they fall through the cracks after we leave here, after they leave here. But then I'll also come across cases where I can just reviewing their chart, I can see, oh, they went to this follow-up appointment, and oh, they went to another follow-up appointment. Oh, and look, they refilled their buprenorphine 3 times. And this person who hadn't been to an office visit in years is now in treatment. And so that's a success for us. So I'll share that with, whichever hospitalist was taking care of the patient. And I'll just say, hey, like, look at this. Thanks for being a part of this. You help make this happen. I mean, I think that can show people that what we're doing actually matters and makes a difference. And I think combats some of the cynicism that comes with kind of taking care of this population.
Beautiful, thank you. All 3 of our panelists answered a question about culture change by kind of pointing at or mentioning stigma. So we don't actually have a stigma question keyed up here, but I'm going to make one up on the fly. So sorry in advance to everyone. My question is not just how do you address provider resistance or individual resistance to this work and stigma reduction, but how do you incorporate other players in that space? Thinking specifically about people with lived experience or other clinicians who are doing this work who have those success stories, sharing those wins. What are some strategies, maybe not the best, what are some strategies for specific stigma reduction? I'm trying to remember the order in which I asked these last questions. Jan, I'll probably throw that one to you first.
Yeah, stigma reduction is a little, it can be tough. But yeah, we've had the pleasure and the privilege of being able to work with peer recovery support specialists at our hospital. I know they started during COVID, and then we had a little bit of a break, and now we're thankfully being able to introduce peer support specialists with lived experience and back into the hospital again. And I think like doctors have a very particular way of talking about substance use disorders that is very different from how patients really talk about it. And we use stigmatizing language without maybe even realizing it, very like sterile clinical language. And so having someone with lived experience to just, first of all, be a support for the patient, but also like meet other people in the hospital. They have a completely different sort of vocabulary and a different sort of mindset to things. And I personally find it really, really refreshing to speak to someone with lived experience and learn about substance use disorder in a way without calling it substance use disorder, for example. And just hearing about the stories of people who have gone through it and come out the other end. I think that's been really, really helpful for us.
Thanks so much. Dr. DeMoss, any specific tools or strategies or educational items that you use for stigma reduction or stigma identification even?
I mean, I don't know why you folks at Dell are being so modest. Y'all have the reset modules, right? The reducing stigmatization training toolkit that you can find on PCSS. I mean, come on, Jan, like tout your horn some, that's fine. That's a great tool. The reset modules. For the audience, just Google UT Dell, stigmatization modules, you'll find it.
I think
so
that's one. Put the link in the chat to the modules while we were talking. So yes, the link to the reset modules are in the chat for everyone.
Oh, there we go. Perfect. All right. So I think that's a great tool. But again, whenever I'm talking to a specific audience, like for residents, other people who are delivering the, prescribing the treatment, we highlight some of the things that keep patients in treatment, such as, the number needed to treat, and 70% of folks, if they're started in the hospital, end up continuing treatment and reduction in mortality, et cetera. And so we use big wild numbers to like, oh, we got to keep these people in treatment, and then we get them with the aha, like, well, how do you keep them in treatment? What language do you use? And so we focus a lot on language used and how you can reduce somebody's anxiety and make them feel more at ease about coming in for treatment if you make them feel, less stigmatized, much less more welcomed, but definitely less stigmatized. And so that's one component of it. The other component for the non-provider kind of folks is focusing on history and just having a conversation about the history of addiction and how it was first defined, and all the addiction legislature and the quote unquote Nixon war on drugs, and just having an honest conversation about where that came from, and using that as a platform to have a conversation about not only stigma for substance use disorders, but also other areas that we have nationally been stigmatized and stigmatizing. So.
I think one of the just to add to that, one of the best things we can do to combat stigma is just to set a good example. Use the right language. Talk to and talk about our patients as humans first, especially when we're talking to trainees, so medical residents, students, and also nurses, especially kind of early career nurses, and other ancillary staff in the hospital. I really think if people hear us using the right language, kind of recognizing our patients as humans first, giving them dignity, I think that rubs off, and also I think kind of selectively critiquing if we hear other people using stigmatizing language, calling patients addicts or users. I think selectively kind of critiquing that can also be helpful.
Thank you. That was so wonderful. I'm going to take a brief pause to just remind our audience that we are going to have we're going to have a time for audience questions in about 10 minutes, a little bit less than 10 minutes. So please feel free to utilize that Q&A box at the bottom of your screen. Throw your questions in there and we'll take a look at those and ask some of those to our panelists. And then I'm going to shift our focus here a little bit away from sort of higher level culture and strategies to a little bit more nitty gritty. So Dr. DeMoss, would you mind talking a little bit about what some key facilitators for success were? So if we've got audience members on the call today who are wanting to do this work or hoping to do this work or wondering if they're able to do this work, what were things that helped you be successful in that?
Yeah, wow, thank you. So you gotta have a group of dedicated folks. So typically a lot of providers, but most physicians, PAs, nurse practitioners don't know how the machine moves. So you really need a partner, be it a nurse, be it a social worker, be it an administrator who knows how the machine moves and how to leverage things in the right places. For us, it was actually one of each, and a psychologist. And so once we figured out how to make the machine move, and the machine I'm meaning like the healthcare organization that I'm at, once we knew how it moved and how to maybe influence which way it moved, then that was just huge about getting some of the executive buy-in to at least give us some early funding to get a pilot up and running, proof of concept pilots, and so that was pretty instrumental. One thing I mentioned earlier, probably the biggest tip I would give to our audience is aligning, making sure your program or whatever it is that you're trying to implement, making sure that aligns with your organization's mission, values, and goals, and leveraging those with the community health needs assessment that you can find in your county or community, And I guarantee you substance use disorder is in there somewhere. And making sure that you can align the organization's mission, value, goals to those community health needs assessment and figure out where you can support that platform with your pilot, that is that is pretty powerful, especially if you can have your champion team, physicians, PAs, nurse practitioners, nurses, social workers, administrators saying the same thing to different groups. That is probably the biggest thing. It doesn't hurt to get some grant funding. That's always helpful, but not everybody's in a grant writing institution. And so the aforementioned approach would be, it was very helpful for us. So.
Dr. Freeland, I might throw it over to you, but also kind of open the question up to not only maybe things that were facilitators, but also maybe unexpected barriers or surprises that you encountered that folks should have on their radar or might need to think about how to work through.
Well, I mean, again, I think that kind of everybody's approach needs to be sort of individualized based on your resources and barriers. So, I mean, and this, I don't know, this might kind of segue into the next, I think, topic, which is more like sustainability, if that's okay.
Mm-hmm.
But like, you know, when we first started out with our consult service, it was just me and a couple of my partners seeing these few consults just kind of on the side in addition to our clinical work, which was extra work that wasn't compensated, and that was not sustainable. But I think it was necessary as kind of a proof of concept and to prove the value of what we were trying to do. As we got going and our volume increased and we had more people on the service, we sort of had to get creative about how are we going to make this sustainable? How are we going to not just burn people out and make this something that we can do long term? And so sort of the creative solution that we came up with was to sort of pair these consult shifts, and our volume was never, and I think will never be big enough that it'll make up an entire clinical shift. It's always going to be kind of a few patients, a couple hours a day worth of work. And so what the creative solution we came up with was to pair our consult shifts with typically rounding shifts, where we'll be sort of quote unquote compensated by seeing two fewer patients than all the other rounders. So those two fewer patients frees up a little bit of time in the day to be able to see these 2, 3, 4, 5 consults on the side. And that was, like I said earlier, with very gracious buy-in from our leadership. So that's just kind of one example.
Love that. Dr. Ramesh, anything to add?
I think one thing is with like sustainability, repeated education sessions is just unfortunately necessary, especially in a teaching hospital when you have residents graduating, people moving on to different things. You're going to get a question every few months like, hey, how do I start buprenorphine? Hey, how do I start buprenorphine? And that's okay. And so doing like that OUD primer, like how do we start buprenorphine every few months is okay and probably necessary in certain institutions. One thing we also did was develop a toolkit of like print resources with our like buprenorphine protocols, as well as methadone and all sorts of things that just live on our intranet that people can access at any time. And that's kind of permanently there for people to access, and we can also share it too with the people on this call if they would like. So that contributes as well. And then also just rethinking how you treat addiction. It's like one of my colleagues was saying yesterday, it's just like treating a patient with diabetes. When a patient with diabetes comes in with hyperglycemia, what do? You start the insulin, you check their A1C, you adjust their dose, you call their primary care doctor and say like, hey, I'm making some changes. it's the same thing with addiction and kind of treating it as like a matter of fact, like, okay, they came in, what were they using? When are they going to go into withdrawal? Can we start this medication? Also helps integrate it into those like learning scripts that we all use for our other patients.
I love that. That's, of course, a metaphor we use often, but I think it's poignant and impactful every time I hear it or we hear it. So we have reached the scheduled end of our prepped questions, and we are intending now to open it up to audience questions. We have one question in the Q&A so far, so congratulations to Brittany Mullen. You win the prize for first question. Everybody else, please feel free to add your questions into the chat. We would love to have an engaged conversation with you. We don't have the ability to unmute our attendees, so I know there was at least one attendee who had their hand raised via Zoom, but we're unable to mute you, unfortunately, due to the panel session settings that we have. But please feel free to enter your question or your comment or whatever it was that you were wanting to say or respond to into the Q&A, and we'll be happy to address that. The question from Brittany is, what might you recommend for small, rural, under-resourced hospitals specifically, which is a big question with probably a very long, complicated answer. None of our hospital sites represented here meet probably any of those criteria, but I'd be curious, Dr. DeMoss, I might hand it to you first, maybe what you would suggest for strategies for a hospital with those characteristics, a rural hospital or a smaller hospital, or one that doesn't have community or internal resources. Where should they start? What's the first thing someone should do?
Well, thanks, Alanna, and thanks, I can't remember the person's name, Brittany, for asking that question. A huge question, huge need. Again, I'm a point to Dell and Be Well. These echo sessions are phenomenal, and you can, through here, you can pair up with somebody, get a mentor. You can get some really good Texas-based hand-holding through Be Well and a lot of folks on here. The other resource I would recommend is PCSS, or the Provider Clinical Support System, I want to say is the name of that. I can't remember exactly what PCSS is, but that's a great resource. A lot of educational stuff on that particular website. And unfortunately, much like Zach over at Baylor, I mean, you may be rural, but if you're in the hospital or clinical setting, these folks they're coming to you. And so the more tools that you have in your toolkit, the more you're going to be able to provide. And so, those are some initial thoughts that I had to get the conversation started, Alanna.
I love that. Thanks, Dustin.
Yeah.
Dr. Freeland, you're off mute.
I think some of the most important things that you would need to get in place is getting a clinical champion, getting buy-in from, figuring out where you're going to send these patients once they leave the hospital, trying to figure out what is the nearest either community-based behavioral health organization that will do medication-assisted treatment, seeing if you have a local methadone clinic, or seeing if there's a primary care physician in the community who is willing to take this on, and then also working with your nurse case managers and social workers to try to help get patients referred to the appropriate place. I think a lot of places, probably all hospitals, just kind of have that old big long packet of here's all the resources that's horribly out of date, and that patients can't even begin to navigate. And so I think patients with opioid use disorder, especially if they're being started on medication-based treatment and need close follow-up, they really need more of a kind of individualized approach to securing close follow-up. I think getting buy-in from pharmacy is also important, especially if you don't have buprenorphine on your inpatient formulary. I think those are just kind of some of the low-hanging fruit.
That was such a wonderful answer. All of those ideas were such tangible things that I think will be so useful to Brittany and others in her setting or with similar questions. Jan, anything to add to that before we move on? We finally got some traction and questions in the Q&A, so we're going to try to get through as many of these as possible.
No, I think Dustin and Zach really covered it on that one.
Well, just one real quick thing I'll add to Zach's comment is if you're out in, rural wherever, it takes just that little nidus. If you can be that little nidus or find somebody who is doing the stuff and help that nidus grow, then you're just doubling, tripling, quadrupling your access on a more outpatient basis. So either be the nidus or support the nidus is what I would say.
I added Google Nidus to my to-do list for after this session. I'm going to answer a question from Brooks Keener, who's actually a chief resident at Dell Medical School in our Department of Internal Medicine. He actually asked two questions. The second question, I think we kind of answered by accident, which was about how do we engage with community partners? And I think Dr. Freeland talked about how to kind of find your players, your people out in the community and figure out how you can engage with them and work together. The first question that Dr. Keener asked was about how to incorporate treatment of OUD or other substance use disorders in general clinical training. He specifically asked for residents, but I would open that up to other healthcare trainees. I'm going to kick that one specifically to Dr. Freeland, because I know that you've done a lot of work incorporating your OUD team into residency rotations and trainings.
Yeah. So we created an addiction medicine 2-week elective for our internal medicine residents, and then our family medicine residents also had something similar. That's a month long. And so I think a dedicated rotation is good because it gives residents hands-on experience, actually evaluating patients, writing for buprenorphine, following them day to day, titrating buprenorphine or titrating methadone. I think just focused education in the form of like noon conference lectures can also be helpful. I mean, I'd be more than happy to talk more about our elective and how we structured that on the side if you want to shoot me an email afterwards, Brooks.
Love that. We're making friends, building community. That's literally the whole point of Shout Texas is to build the statewide community to make change for our patients and our neighbors. Let's see. So we're right about at 12:55. So we're wrapping up at 1. So I'm going to unfortunately pause our audience questions right as we started to get some momentum. But we will retain these questions and potentially can send out maybe some individualized responses or responses to these individual questions to the larger group as a post-session material after this. So I want to take the next couple of minutes, specifically exactly 3 minutes, for a kind of a lightning round wrap up. Each of you gets no more than 60 seconds. For our attendees here in the audience looking to get started today, tomorrow, next week, today's Friday, so Monday, looking to get started on Monday, the first step or the first thing they should do when they're thinking about how they want to design a program like this. I do not remember who answered the last question, and both Dr. DeMoss and Zach are off mute, so I'm just going to guess. Dr. Freeland, why don't you take the first stab at that one?
I apologize. I was writing the chat. One more time.
No problem. Sorry. What would be the first thing that somebody who's looking to get started doing this work in their facility, what's the first thing they should do or first step they should take to get ready?
I think I was just going to repeat what I said earlier. I think you got to start with a champion, figure out who else you've got on your team, try to expand that, get buy-in from the necessary folks, and just figure out a game plan. And I think sometimes you just have to kind of jump in and start doing the work. If you hear there's a patient with OUD who's in withdrawal, like go see him or figure out who's best suited to see him and start treatment. And then later on, figure out, is this going to be a recurring thing? How do we systematize this so we have a plan for these sorts of patients in the future?
Alanna, you're on mute.
Made it almost through the whole thing. Darn it. Dr. DeMoss, I was passing it off to you for your no more than 60-second response.
I suspected that was the case. Again, like Zach, I'm gonna say something I said earlier, which is be the nidus or find a nidus and become your own nidus, which really just means like if you're wanting to know, I'm gonna use OUD specifically here. If you want to know how to finally treat, like I've seen them, I gotta do something about it. Educate yourself, and in concert with that, find a mentor, find a BUPE buddy, which is something that we coined here. Thank you. And you call the MAT phone, the MAT phone, and find your BUPE buddy on the other end. Like, okay, walk me through what do I specifically need to type in this EMR to take care of this person with these clinical symptoms. We found that to be just immensely helpful because clinicians who are used to managing, DKA as an outpatient, I'm being a little facetious here, but people who are used to managing very complex patients for the first time, even though they're 10, 20 years out, for the first time ordering that, they're going to want a warm hand to hold. So if you're that warm hand, put your cell phone out there for everybody. If you're looking for that warm hand, find somebody's cell phone or email like Zach's or somebody else's through Be Well or text us. It's a great organization to find mentors.
Thank you so much. Dr. Ramesh, you get the last 60 seconds. What's the last thing you want all of our attendees to know about first things they should do on Monday morning?
Well, I'll try to echo some of the spirit of how the B team initially started, but it's easier to ask forgiveness than it is to ask permission. So kind of echoing what Dr. Freeland and Dr. DeMoss said, if you see something, just start buprenorphine. Don't try to like ask around for, can I do this? Can I do this? If you feel comfortable doing it, just start it and see what happens. And then one other thing that we like to say here is see one, do one, teach one, especially at a teaching hospital. If you can do it and then demonstrate to maybe a senior resident or something else like, hey, this is how I did it, and then have them do it next time and demonstrate to the intern, then that's a good way for the model to spread and for more people to become comfortable with prescribing the medication.
Thank you so much. Thanks again to all of our panelists. Lots of resources in the chat for folks to grab, and I will hand it over to Dr. Lindsay to wrap us up. Thank you all, everyone.
Thank you so much, Alanna, for that fabulous moderation. Thank you for our panelists. Just excellent information all around. As Alanna mentioned, we will take down all the questions from the Q&A segment and try to return some answers to folks as soon as we can. And you probably saw the link drop for the post-session survey. So just a reminder, if you need CE credits, please go ahead and complete that. But even if you don't, we really like to hear your feedback, what was helpful, what was not as helpful. There's also a place in that survey to let us know what other topics you'd like to see at future Texas sessions. And I'm surprised it didn't come in the Q&A. I thought it may, but I know there are probably remaining questions about when we will be rescheduling the symposium. Thanks to all of you for your patience with that. As everyone knows, with funding changes and regulatory changes, we did need to postpone the symposium this year, but we have some exciting announcements coming soon. We will be rescheduling that event, but we'll continue having these Texas sessions in the meantime so we can all keep in touch. So thank you again to Alanna, thank you to all of our panelists, and thanks for everyone who joined today, and have a great weekend. We will see you again soon.